Oh, welcome back. And I want to look at the two trials that we talked about at the end of the last video. One trial conducted in London, based in St Mary's from London, appears to show that vitamin D is not protecting against COVID-19 infection or other infections from acute respiratory illnesses. Now, this is surprising because it does contradict previous research we've looked at on this channel that shows that good vitamin D levels prevent against influenza infection. So we have to bear it in mind in context of other studies, but it is a study, so we're going to look at it. And this is it here. Now, we do notice it's in preprint format. This was the original request and background for the trial there. And we expect this to be peer-reviewed in the next few weeks, I would have thought. Hopefully this will be peer-reviewed fairly quickly. Interesting to see if the peer reviewers come up with many modifications that are required for that. So at the moment it's in preprint format. And then here's the other study we want to look at here in a minute. Now, this one is from Israel. And this seems to show that vitamin D protects, or good levels of vitamin D protect against severe disease. And this could well be the case. So it could be that levels of vitamin D are not protecting very highly against COVID infection, but are protecting against severe illness, hospitalisation and death, which of course is the more important thing. And in fact, you could argue that it's good to be infected with COVID if you get minimal disease, because that's going to give rise to immunity, natural immunity, which we believe is the best form of immunity. So let's start off with this trial here to begin with, and we'll go through it. So basically, remember, I'm not really seeing a contradiction here. That one trial showing that it's not protecting against actual infection, but another trial, consistent with many other trials we've looked at, seeming to show protection from more severe disease, or at least a correlation with good vitamin D levels and lower levels of severe disease. And of course, this is only talking about infection with COVID. We know with vitamin D and COVID and other infections, we know that vitamin D is necessary for activating about 2,000 genes in the body, and that there's vitamin D receptors in all of the immune cells and probably in nearly every cell in the body. So it's only looking at one aspect, but it's important to look at it. So let's kick off. So here's the study. Vitamin D supplementation for prevention of COVID-19 or other acute respiratory infections. And as we say, this is the London-based one. This is the trial. Now, the data here was taken from December 2020 through to June 2021. So there's a 6-month follow-up, and that is a good follow-up. That's quite adequate. Quite happy with that. Now, they randomly assigned 6,200 UK adults, and they had a postal finger prick test of 25 hydroxyvitamin D levels to show what the levels were. Now, this is the 25 hydroxyvitamin D is the way this is actually measured in the blood. Now, you might remember that we actually did a couple of these ourselves on this channel about probably a couple of years ago now, 18 months ago at least, and we did find different results from 2 finger prick tests. So quite how accurate that is, we don't really know, but nevertheless, this is what was done. And if people's vitamin D levels were low, they were given a 6-month supply of vitamin D, and we'll see the doses in a minute. But people were only given vitamin D if their blood levels were less than 75 nanomoles per litre, which is 30. So that's actually divided by 2.5, so that's 30 nanograms per mil. It really is a pity that we've got two ways of measuring this, but this is the UK measure, so we'll stick with this for this study. Less than 75 nanomoles per litre. Now, if the levels were less than that, and this is good because it means that they are selecting people with the lowest vitamin D levels. If their vitamin D levels were lower than that, then they were given, some were given 3,200 units a day. Bit of an odd number to pick, 3,200 units a day, but there you go, that's what they used. And others were given 800 units a day. So there was a higher dose and a lower dose. And there were those that were offered no testing or supplementation. So that's the third group with no offer of testing or supplementation. So that they were just carried on in their own sweet way. They were given an extra 3,200 a day. They were given an extra 800 units a day. And they did checks, and the compliance with this was good. So we do believe these people were actually taking these supplements. Of course, it tells us nothing about the vitamin D status of the other group. They were just carrying on in their own sweet way. So they were none offered or not. They weren't offered testing, and they weren't given supplements. Of course, they could have been taking supplements on their own if they were vitamin D aware. So that's a slight compounding variable in the study. Anyway, outcomes. Proportion of participants experiencing at least one swab test or doctor diagnosed acute respiratory infection of any cause. So any acute respiratory infection, and also incidence of PCR confirmed COVID-19. So they were the two outcomes. Now, 2,690 people had low vitamin D levels. Now, this in its own is interesting. So 86.8% of the population already here had what we would call lower than I would believe to be optimal vitamin D levels. So that was interesting. But who experienced at least one acute respiratory tract infection? Now, the higher dose group, there was 76, which is 5%. Who had the high, so they had the 3,200 units of vitamin D. These ones had the 800 units of vitamin D a day, and they also had 5.7% of them got infections. And the group with no offer, who were just left to go their own sweet way, 4.6%. So we see the higher dose of vitamin D, 5% infections, acute respiratory infections. This is not COVID. This is any respiratory infection. 5.7 on the lower dose and 4.6 on the no dose. So the higher dose versus the no offer dose is the odds ratio is 1.09. In other words, we see that the people with the the higher dose versus no offer. So we see the people with no offer actually had less infections than the people on the high dose of vitamin D, and the lower dose versus no offer 1.26%. So again, the lower dose having more infections of vitamin D. Now, there's no reason why the vitamin D should be causing more infections, so we basically have to say that these results are not significantly different. Now, this is surprising, and it is inconsistent with several other studies we've shown that people that are deficient in vitamin D are significantly more prone to influenza infection. So these results are surprising, and that's why I'm interested to see if peer review comes up with anything. I mean, I've obviously read it. You can get the whole, you can get the PDF there. You can get the whole thing. It is all there. So the detail is available, and it looks fairly good to me. The only thing I actually found that was wrong was this 6,200 people that they chose. There was actually a larger sample to begin with, and they actually picked the ones they wanted to be in the study. Now, that could lead to some human subjectivity, which is always the issue in clinical trials. But apart from that, it seemed a pretty good trial. So there could be some human subjectivity in that, although St Mary's and St Bart's are going to account for that. These are not amateur researchers. So, but interesting to see if peer review does come up with anything on that. So we'll keep an eye on that. So anyway, that appears that vitamin D is actually leading to high levels of vitamin D are actually causing more infections. But as we said, the result is not significant. In other words, we can say there's no difference here between the higher dose, the lower dose, and the no offer group dose. Surprising, but that is what the evidence is showing. Diagnosed with COVID, so higher vitamin D group, that's the 3,200 group. Lower dose, that's the 800 group, and that's the go their own sweet way group. So again, the higher dose group, 3% of those had a COVID infection. Lower dose group, 3.6 had a COVID infection. And again, the no offer group, only 2.6 had a COVID infection. So again, showing no significant difference. And they did stats on these, of course, and the differences aren't significant. So even though it looks like the no intervention group got less, the difference there is not significant. So very surprising and inconsistent, it has to be said, with other studies that we have looked at. Conclusion of this group. Implementation of a test and treat approach to correcting suboptimal vitamin D status in the UK population. So this is good because remember, people with only lower doses of vitamin D had the supplement. It was safe and effective in boosting the levels because they did check some of the levels after. So it was safe and effective at increasing the levels on people that had low levels. So safe, effective, fine thing to do, but not associated with protection against all-cause acute respiratory infection or COVID-19. So there we go. But with so much of the virus around, it's not surprising that a lot of people did test positive even with higher doses of vitamin D. And it could be, there's a difference here between the mucosal compartment immunity, which of course is the first line of defence, and the vitamin D, which is more the internal line of defence. So it could be there's a difference there, but we don't know. Just taking that paper in isolation, vitamin D is not helping to prevent actual infection. But as I say, that is inconsistent with other data, so we await. Now, what about severe disease? Well, the authors were very clear on this. Incidence of hospitalisation for acute respiratory infection was low, and we therefore lacked power to detect any effect of the intervention on severity of COVID-19 and other acute respiratory infections. So this was just whether people were diagnosed with it or not. This tells us nothing, and the authors are quite clear about this, this tells us nothing about the severity of the condition. Because whether we get the infection or not doesn't bother us too much. In fact, it's good because we want the immunity. What we don't want to do is get sick, of course. And that's where I want to use this study from Israel to compare, because this one did look very precisely at severity of COVID-19. That's exactly what it looked at. So let's look at this by way of comparison. Pre-infection. So they looked at people's pre-infection 25-hydroxyvitamin D levels in the blood, same criteria, and association with severity of COVID-19 illness. So this one is severity, whereas the London study was whether they got it or not. So this is the Israeli study now. Objective, examine if and to what degree a relationship exists between pre-infection vitamin D levels and disease severity and mortality due to SARS coronavirus 2. Now, it could make sense that there's a difference here because we know that vitamin D is necessary for immunity because vitamin D receptors are present in immune cells. They're there, we know they're there. But we also know that vitamin D is an immunomodulator. So if people have got very low vitamin D levels, we believe it can increase their immunity. Although the London study, to be fair, doesn't show that. But we do believe that from other studies. But high levels of vitamin D or good levels of vitamin D will also prevent the excessive inflammation. It's an immunomodulator, so it'll prevent very small immune reactions. And it'll prevent overreaction as well, which is what caused the acute respiratory distress syndrome. And so it's an immunomodulator, making sure the porridge is not too cold and not too hot, but just right. That's what the vitamin D is doing. So good levels should reduce the degree to which people get this hyper-inflammatory cytokine storm type of reaction. So participants, now this was the 7th of April 2020 through to February 2021. So again, plenty of infection around. Galilee Medical Center in Israel. All cases were diagnosed with PCR, as you would expect. Now, in Israel, they do a lot more vitamin D testing than we do in this country. So they had some much more data on people that had been tested with vitamin D, been tested for the vitamin D levels, and then subsequently developed COVID-19 infection. So they had this more historical data, which we lack very often in the UK. Historical data levels measured 14 to 730 days prior. Now, of course, if it's a long time, there's no reason why it should still be the same, but it's the best we've got. Design participants admitted with COVID-19 were categorised according to disease severity and level of vitamin D. So they were looking at disease severity, and they were correlating that with levels of vitamin D as recorded for those people in the past prior to their infection. Were they deficient, insufficient, adequate, high, normal? And they did, it's quite clever, they isolated for the influence of the sinusoidal pattern of vitamin D. So what happens is vitamin D levels go up in summer and down in winter. Up in summer, down in winter. We get this sinusoidal pattern pretty well everywhere. But they were able to account for that. Now the results. 1,176 participants, but they had data on 253 people on their pre-morbid, their pre-hospitalisation vitamin D levels. So no, it's not a brilliant sample size, but it's not bad. It's a reasonable sample size. Now, in patients with severe and critical illness, 87% had low vitamin D levels, lower than 20 nanograms per mil. Now, again, they're taking the nanograms per mil. So to get that into the British measurements, we'd have to multiply that by 2.5. So that's the conversion difference there. Anyway, 87.4 had lower vitamin D levels than 20 nanograms per mil. In patients with mild or moderate disease, 34.3 had lower vitamin D levels. So patients with severe or critical disease, high proportion had low vitamin D levels. Patients with mild or moderate disease, a lower proportion had vitamin D levels, below 20 nanograms per mil. And the probability that those two figures arose by chance were significant. In other words, there's a genuine difference between this group here and this group here. That is a genuine, significant difference between those two. It's a real difference. But patients with less than 20 nanograms per mil versus patients with greater than 40 nanograms per mil. So patients with less than 20 nanograms per mil were one group, and patients with greater than 40 nanograms per mil were the other group. So we can compare those with less than 20, those greater than 40. And again, that gives us a comparison between those two groups. Patients with lower vitamin D levels were 14 times more likely to have severe or critical illness. So if the vitamin D levels were less than 20 nanograms per mil, they were 14 times more likely to have severe or critical disease compared to those with over 40 nanograms per mil. So taking the lowest and the highest and looking at the difference between those indicates 14 times more likely to be severely ill with low levels of vitamin D. So there's not necessarily a contradiction between these two surveys. Let's just look at the conclusion of that before we conclude. Among hospitalised COVID-19 patients, pre-infection deficiency of vitamin D was associated with increased disease severity and mortality. So that correlation is there. Now, these studies aren't necessarily contradicting each other, because it could be, as we've said, that vitamin D is not protecting against actual infection, as detected in the London study by the remarkably sensitive PCR test, it has to be said, whereas in Israel, this is looking at severe disease outcomes. So I feel that Sajid Javid is completely correct in launching the national survey to consider ways to increase vitamin D levels in the population, as he's declared he wants to, and to increase awareness amongst individuals, healthcare providers, and looking at ways to increase vitamin D levels. I think he's completely right to do that. For COVID, it's likely that when we increase vitamin D levels, that's going to reduce severe disease, the incidence of severe disease. But we also believe it will help with numerous other conditions as well. At least that's what I believe. And I think there's certainly many correlations there that indicate that. So there we go. Two interesting studies. Now, there are many other studies. There are several other studies that we could have chosen that show similar results to the Israeli one. It's just that doing more than 2-on-1 videos, probably too much. So there we go. Interesting. Now, as soon as we get the peer review on this study here from this St Mary's study, as soon as we get the peer review on that, we'll look at that with interest. Just get the feeling there's something not quite right. I mean, the study's been well conducted, but I think there might be something that the peer review will pick up that I've missed, because it is inconsistent with other studies, but that's what we've got at the moment. That's the level of evidence. We are now up to date with the current developing discussion on vitamin D and COVID, vitamin D and acute respiratory infection, and vitamin D and numerous other conditions. But we can only look at where the trial evidence is. I mean, in vitamin D, low levels again are associated with things like colon cancer, prostate cancer, recurrence of prostate cancer, increased heart disease, diabetes mellitus, multiple sclerosis, other autoimmune diseases, and there is evidence for these things. But nevertheless, from this study, it shows that people with better levels of vitamin D were not getting protection from COVID infection, at least, although the study told us nothing about the severity, whereas other studies have. Quite interesting, isn't it? Currently, as I've said, I'm taking 4,000 units of 4,000 international units of vitamin D a day, which is 100 micrograms, but with about 100 micrograms of vitamin K2 to make sure the calcium goes into the right places. That's what I'm taking, if you want to know what I'm taking. It's not telling you what to take, but that's what I'm taking. Anyway, thank you for watching.